We are starting off with the first section. In this section, we are talking about the anastomosis. This is a lecture on anastomosis, drains, and diathermy, the practical aspects of surgery. So this section would include the bowel anastomosis, the vascular anastomosis, and finally we are going to talk about the laparoscopic anastomosis. So let's get into it and see what the details are. So the bowel anastomosis. So it comes from Greek word and it's an amalgam of two words actually. Ana means without and stoma means mouth. So anastomosis in itself means without mouth. That is, there were two tubes that were open and now you've connected them and formed a junction between them. So let's talk about a little bit about the history of bowel anastomosis. So first of all, it was suggested by Lambert. He was the first surgeon to attempt it in 1826. And he suggested that seromuscular suture technique for bowel anastomosis was the most efficient. That is, you should always take a bite. The suture bite should include the serous component as well as the muscular component. That is the third layer of the bowel and the fourth layer of the bowel. What Lambert was trying to say was that you should always have a deep-seated suture, and a deep-seated suture would help you in achieving a well-sealed bowel anastomosis. Now we can continue with this, and we see Sen coming along, and Sen says two-layer technique for closure of bowel is more applicable, it's way better than the one-layer technique. Now Lambert was saying to place a deep-seated suture. Now Sen is saying you place two layers of sutures, one deep-seated and one a superficial layer. This two-layer technique was revolutionary. It helped the surgeons to attain watertight and airtight seals in their anastomosis, and this resulted in better outcomes of the patients. Now we have the Kocher's method. In Kocher's method, there's a two-layer anastomosis as suggested by Sen. However, the first layer is continuous, and this first layer is applied by using catgut. Now the second layer, which is interrupted sutures, is usually applied using silk. So catgut and silk were used. Catgut was used in the first layer and silk in the second layer. The silk layer was of interrupted sutures. Now using catgut and silk, these were the biodegradable. These sutures had difficulty in their degradation. Their degradation was non-predictable. So with these, the non-predictable results were found in various patients. So they needed something else, something better. Now, with advancement of technology, we got a hold of better sutures, and with better sutures came newer methods. So the Kocher's method was the mainstay of bowel treatment, despite it being slightly unpredictable. Now Halsted comes along, and what he suggests is that there should be another extra layer of extramucosal closure. Now the second layer, which was initially submucosal, has now shifted to extramucosal. Now when the layer was extramucosal, this resulted in less charring, less damage to the tissues, and less necrosis. Now subsequently this was advocated by Matheson as well, and this led to least tissue necrosis or luminal narrowing. So this was a little bit about the history of bowel anastomosis, as how it has progressed from single layers deep-seated sutures to two layers of luminal sutures, and finally from catgut and silk to the newer types of sutures. Now moving on, now what do? We use one layer extramucosal closure technique. This includes the submucosa. Here you can see this is the deep lying suture. With that we tie up the serosa and the muscular layers. This is a submucosal suture, and with this we tie the superficial layer. Tying of the superficial layer with this results in lesser necrosis and lesser chances of luminal narrowing. So a lot of randomized trials were done on various suture techniques, various types of sutures, the two-layer technique, the single-layer technique, what was better and what was not. Finally, it was found out the two-layer technique was best because it avoided any slippage. It helped in the maintenance of airtight seals, the watertight seals. Hence, the two-layer is now recommended. Now, catgut and silk, they were replaced by synthetic absorbable polymers. And why is that? We've talked about it. The degradation of catgut and silk was not as predictable as initially thought to be. It was found out that in various types of patients, the catgut and silk showed various behaviors. Now, within the human body, when there was presence of pus, infection, or feces within the wound, the behavior was further deteriorated. Now, with this type of suture, it was very difficult for a surgeon to predict the strength and the duration for which the suture will stay. So now they replaced the silk as well as the catgut with absorbable synthetic sutures which had a dependable life. Now, bowel preparation, a very important topic. Older surgeons still to this day believe that bowel preparation is very important. They give various purgatives, various laxatives so that you should prepare the bowel for what is about to happen. But bowel preparation is now not recommended. Some say the bowel preparation might even it might not even help the patient. It might be deteriorating the condition of the patient further. So now you do not make the patient undergo bowel preparation. However, initially bowel preparation was very, very important. And the risk of intestinal spillage, for example, in atraumatic intestinal clamps are used to prevent the risk of intestinal content spillage. That is very important. So you should always ensure the good blood supply to bowel ends. Again, very important. You should use atraumatic clippers. You should always make sure that blood supply is adequate. Oversewing if excessive bleeding. Now, this is important. If you see the edges are excessively bleeding, you should oversew. You should make sure there are no bleeders in there. Now, use of atraumatic bowel clamps is very important because bowel is a very sensitive and a very delicate organ. So always use atraumatic clamps, atraumatic forceps, so that you might not injure the bowel itself. Now, interrupted and continuous layer sutures are applied. Now, interrupted and continuous, whatever the need may be. Now, you see an area, you can throw continuous sutures, fine. You see an area you cannot throw continuous sutures, you can use interrupted sutures. Now, that depends on your skills, your expertise, and the requirement at that point in time. So, you have to decide what type of suture you'll use at that point in time. Now, how to do it? So you have to ensure that the anastomosis is under no tension. That is the rule. That was the rule of wound closure as well. Whenever you're closing a wound, whenever you're closing an anastomosis, there should be no tension. All right. That is the rule of thumb. So you should always use stay sutures. And why to use stay sutures instead of forceps? I've mentioned it before. Forceps can damage the bowel because bowel is a delicate organ. Stay sutures keep the bowel in position, keep the openings in position. You can easily access them, and they're not traumatic for the bowel itself. So stay sutures are very helpful. Now, the suture bite should be 3 to 5 millimeter deep and 3 to 5 millimeter apart. It is just an approximation so that you might get an idea of how deep you should be going. So the suture bites should be 3 to 5 millimeter deep so that you are enclosing the mucosa, the serosa, the muscular layer as well. And they should be 3 to 5 millimeter apart. So there's not extensive tension on the wound and there's no tissue necrosis. Now, the suture bite, they also depend upon the bowel thickness. Now, why is that important? In an obese patient, you will have extensive bowel fat, and a 3 to 5 millimeter deep suture might not cut it. So you should keep that in mind, and the depth should always depend upon the bowel. So that was the reason I said 3 to 5 millimeter was an approximation. Now, the suture material should either be 2-0 or 3-0 in size and should be absorbable. So why the absorbable material? Again, so that there might not be tightening or there might not be necrosis. You can use either the braided sutures or the monofilaments. Now, we've talked about it before. The monofilament is a weak suture. Braided suture is comparatively strong. So whatever the need may be, you can either use the braided suture or the monofilament suture. Now, in end-to-end bowel anastomosis, the bowel of similar diameter are brought together. Now, why is that? It's very simple, actually. It's simple mathematics. You're trying to join two tubes. You're trying to join two pipes. So what you'll try that the diameter of both the pipes, both the tubes should be equal so that you can easily join them. So that is the reason in end-to-end anastomosis, you always require both that the diameter of both the tubes should be equal. Now, in side-to-side or in end-to-side anastomosis, size discrepancy can be there. So if you see size discrepancy, you should always go for end-to-side or side-to-side anastomosis. Now, Shillette spilling, when discrepancy is not marked, that is important. You should always know the discrepancy beforehand. You should always have a plan that what you are going to do in your patient. You should always perform the pre-surgical evaluation, and your pre-surgical plan should always include what happens, what is your second plan of action if your first plan of action does not go as you're planning. Now, the closure of mesenteries is a must. So now, you have cut a section of the bowel, the section of the damaged bowel. You have cut the mesentery along with it. Now you brought together two other portions of the bowel. Now you have to close the mesentery of those portions as well. It is very important, otherwise the bowel may herniate within itself, within the mesentery, and that would be the surgeon's fault. Now, this is done to prevent the risk. You should always prevent the risk to mesenteric vessels. Now, again, a very important point. The mesentery is rich in blood vessels. You should always, it can clearly be visualized. So you should always visualize the mesentery and make sure when you are sectioning the bowel, you are not damaging the blood supply to other parts of the bowel itself. Now, moving on to the vascular anastomosis. So, vascular anastomosis requires extremely accurate closure. Now, why is that? Vessels are under constant pressure, the systolic and the diastolic pressure. Whatever you might do, your vessel anastomosis should be watertight. It should not leak the blood. It should not ooze any material from it. It should be strong enough so that it can sustain systolic pressures of even 180, 190 millimeters of mercury. So your vascular anastomosis needs to be perfect. Now, it needs to be permanent and integrated within the vessel itself. And you can also use prosthetic material. Sometimes there's extensive damage to the vascular tissue, and as a result of which it cannot be repaired by itself. You can use a prosthesis for that. But whatever prosthesis you are using, whatever prosthetic material you're using should be strong enough to withstand the systolic pressure in a human being. So in the bowel, you normally prefer non-absorbable sutures. And why is that? Now, non-absorbable sutures would not be absorbed. Since they would not be absorbed, they would provide strength for longer periods of time. You must understand that a non-absorbable suture does not get not absorbed forever. There is a half-life, there is a time till which the non-absorbable suture stays. After that time, even the non-absorbable suture is disintegrated. It loses its strength. However, the time during which the non-absorbable suture maintains its strength is the time the vessel repairs itself. So it is always recommended to use a non-absorbable suture in vascular anastomosis. Now, the suture line should be regular. It is very important because an irregular suture line would cause thrombosis and chances of distal thromboembolism. And finally, the suture size, it depends on the vascular caliber. So depending upon the size of your vessel, you select the suture. You might choose 2 knot for aorta. You might choose 4 knot for femoral arteries, 6 knot for popliteal and distal arteries. And all of these should be taken on an atraumatic round-bodied needle. So this was just an approximation. You always look at the vessel, you see the diameter of the vessel, and you decide what type of suture you might require for this vessel. And the needle used would be a round-bodied needle. Now, the knots, they require multiple throws. So best would be a surgeon's knot or a reef knot or a modified reef knot. And the knots should be perfect and should hold in positions because the knot is what is holding the suture line in place. If the knot is loose or if the knot is unbridled, that would be a catastrophe. So again, this is an anomaly in the vessel. This here you can see an open tear in the vessel, and this is how the vessel is being repaired. The sutures are being thrown, the suture has been tied, and the vessels are this is an end-to-side anastomosis, and with this the vessel has been closed. Now, you should always be careful with the use of vascular clamps. Vascular clamps, though they're atraumatic, but still should be very careful with their use because they can still cause significant damage and spasm of the vessels. It is usually advised to use DeBakey's because DeBakey's clamps are very sophisticated and they provide little resistance and little damage to the vessels themselves. Now, the proximal clamps should be released first. Now, with the release of proximal clamps, the chances of distal embolism, they decrease. What happens is when you release the proximal clamp, any clot that has been there, it would be drained, and with the drainage of this clot, the chances of distal thromboembolisms, they decrease. Now, distal clamp is released first and before the final watertight knot is made. So, you release the distal clamp when you have to, before making the final knot. So, why is it released? Because you have to check that the knot you're throwing is watertight or not. So, do you release the clamp and then you tie the knot and check for the watertight status of that knot. Now, your assistant should follow by keeping the suture taut once the closure is complete. So it's a surgeon's and it's provocative to always follow the suture, and while following the suture, the surgeon should always keep it taut so that the closure is perfect. Now, the needle insertion should be at 90 degrees. We've talked about it before. It's always at 90 degrees to the surface of intima, and the needle curvature should be followed in its entirety to prevent any damage to the vascular tissues. Now, you should pass the suture from within to without on the downflow aspect of the anastomosis. So you always start from within and then you pass the suture to the outside. From inside to outside, the suture is passed so that there should be minimum damage to the vascular tissue itself. So how do you suture the vascular anastomosis? Now, the suture bites should be placed at an equal distance apart. Here you can see in the figure, they're at equal distance apart. We've talked about it. The distance is an approximation, but it should be almost equal, so that equal strength is provided throughout the suture. Now, all the hemostats that are used to hold any suture material should be shod with soft rubber. And why is that? Because this prevents further damage to the vessels. So vessels, they are being extensively damaged by the hemostats. not extensively damaged, but somewhat damaged. Shotting them with rubber, it reduces the damage to the vessels that might occur. So this is very important. Now, to avoid the damage to the suture material itself, it should not be gripped with the surgical instruments, and the bite size should depend on the vascular diameter. Now, in aorta, you'll have a greater bite size. Now, why is that? Because the muscular component, the media, the muscular component, the serosa, they are thickened in the aorta. However, in the popliteal vessels, you'll have a smaller bite size because the muscular component, the muscular layer, would be smaller. Now, what is arteriotomy? So, there are two types of arteriotomy. There's transverse arteriotomy and there's longitudinal arteriotomy. So, let's compare the two. Now, the transverse arteriotomy is less likely to stenose. However, the longitudinal arteriotomy is easier to make. Now, transverse arteriotomy might not give adequate access, while longitudinal arteriotomy, it is more likely to stenose, but it gives you the better access. So you should make a compromise between the two. Arteriotomy is simply an incision in the artery itself so that you might enter the lumen and perform your surgery there. So you should understand the difference between a transverse and a longitudinal arteriotomy, and should make sure what type of arteriotomy you are going for before you enter your patient. Now, in an arteriotomy, the suture line can be started at the apex of the arteriotomy. So the suture line is always started at the apex in arteriotomy. The use of double-ended sutures, and then it should be carried down each side. Now, this is the apex. Now, here you can see the suture line has been started from the apex here. Now, the suture line has been started, and they're taking the suture line towards the end on each side. Now, it has been taken down each side. So, this is how you proceed in arteriotomy. Place a final knot being at midpoint of the vein patch graft. So, at the midpoint of the graft between the vein and the patch, you place your final knot. Now, the suture again goes from outside to inside on the graft. The directions are reversed on the graft and the artery itself. Now, on the graft from outside to inside, and on the artery from inside to outside. So this minimizes the risk of the intimal flap formation. So what is a flap formation? We know the intima can be separated from the vessel itself, and it can form a separate flap. So when you pass the needle from the flap, from the graft into the intima, into the vessel itself, this prevents the formation of intimal flap. Now, how do we perform the laparoscopic anastomosis? So, let's see, this is a laparoscopic device being used, and this device would be used to perform a laparoscopic anastomosis. This section of the bowel has been removed. Now, this section has been brought together. Here, two suture lines have been drawn, and this will finally be anastomosed with each other. Now, let's see how that happens. So you first have to ensure that the portions of the bowel you're using have good blood supply. Then the tension should be avoided. As we've talked about earlier, no tension between the bowel tissues, and there should be gentle handling of the tissues. These are some of the prerequisites of surgery, be it laparoscopic or open. Now, both the sutures and stapled anastomosis can be done. This is suture anastomosis here. This is the staple anastomosis. So both the suture anastomosis and the staple anastomosis can be done. You can choose from either of the options. Now, extracorporeal anastomosis if bowel is mobilized. So if the bowel is extensively mobilized, you perform an extracorporeal anastomosis that are outside the body, and intracorporeal anastomosis is performed when one or both ends of the bowel cannot be exteriorized. So if both the ends of the bowel can be exteriorized, you exteriorize them and perform an anastomosis extracorporeally. However, if one or both ends cannot be exteriorized, what do? You anastomose the bowel within the human body cavity. Now, intra-abdominal surgery is also performed, and enterotomies are performed. These are also types of laparoscopic anastomosis being done in the abdomen itself. So this was all about laparoscopic anastomosis. So in this section, we've talked about anastomosis in details. We've talked about various types of anastomosis. I hope you understood and liked this section. For further such sections, keep watching sqadia.com.